It felt like a tension. It was like a tension between the technical and the human experience of suffering. And I think that started to shape the way I saw medicine. In Chile, between 40 and 50% of the population is dying in hospitals, and a lot of them in critical care units. The collaboration between intensive care and palliative care is not only possible, but absolutely essential. So it's very helpful for us that we, over the past 2 years, 3 years, we are developing a government-funded research project that aims to evaluate the effectiveness of a palliative care protocol for patients at high risk of death in ICU, in our ICU.
A professor of internal medicine at the University of Chile in Santiago, Dr Palma is head of continuous and palliative care at the university's clinical hospital. For nearly 2 decades, she's been a driving force in establishing palliative care as a recognised medical subspecialty in Chile, leading the National Certification Committee and creating innovative telemedicine programmes that provide free palliative care education to physicians across the country. Dr Palma's research focuses on symptom management, communication, and spirituality in end-of-life care, and she currently serves on the board of the International Association for Hospice and Palliative Care. Dr Palma, welcome to Palliative Care Matters.
Thank you, Jane. I'm very happy to be here. Thank you very much for the opportunity to sharing a little bit about our experience in Chile. I currently work at the University of Chile Clinical Hospital. It's a teaching hospital with around 400 beds. It's a very urban city with about 7.5 million inhabitants. It's a high populated city. And we provide care for both public and private sector patients from across the country. So I led the palliative care unit, and my day-to-day work is very team-based. We have a mobile team. Our team includes physicians, nurses, and psychologists. And we work as consultation team in services like surgery, internal medicine, and sometimes intensive care. So that's my clinical work. We have also students and research duties. As for how I developed my interest in palliative care, it goes back to my residency in internal medicine, when I spent time rotating in different services and also in intensive care units. I found the technical precision, all the physiology behind caring critically ill patients fascinating. The challenge of trying to treat, to stabilize someone in such delicate state, very ill people, was very interesting to me. But at the same time, and maybe in a paradoxical way, I became deeply aware of the distance between what we do as technicians in terms of complex treatments and how abandoned patients and family felt when there was no longer a chance of cure. I felt like a tension between the technical and the human experience of suffering. And I think that started to shape the way I saw medicine. And after my residence in internal medicine, I pursued postgraduate studies in palliative care. I was looking for a balance between a good medical practice and the importance, the humanity behind the patients. Finally, we are there to treat patients, and the humanization of our work, I think, is so important. So that was the beginning, and that helped me to deepen the competencies of palliative care, so communication, decision making, teamwork.
Are you, just to ask you, are you able to do that, or were you able to do that training, specialization in palliative care in Chile itself in those days, or did you have to travel outside?
No, girl, I have to travel outside. I went to Belgium, to the Institut Bordet at Bruxelles. Because in Chile at that moment, that's when the year 2002, that was nothing in Chile to make specialized studies in palliative care. So I went there and I made that in Belgium.
Okay. And nowadays, can people locally train in palliative care with your team and the various developments that have happened over the last tasteless years?
Yes, but not too much. We have a national certification because we have a national system of palliative care that have a government financially support since 2004 for cancer patients. And a lot of people start to work in palliative care units without qualifications. So to do that, it's necessary, we have to do that. And after 20 years, a lot of physicians make self-formation programs like me, like other people. And we start to give the certification for those people in 2021. But the only university program that we have is a 1 year sub-specialization in the Catholic University. But we still don't have strong university palliative care programs in the country. We are building that.
Yeah. So some progress and some way to go. But we are today going to specifically focus on palliative care in intensive care units, which I know is a particular area of interest of yours and an area in which you have conducted quite a bit of research. So could you tell us a little bit about how palliative care in Chilean intensive care units has evolved?
Yes, well, I can tell that the COVID-19 pandemic was a start point for me. Our hospital went through a massive reorganization during the COVID-19 pandemic, turning regular wards into intensive care units as part of a national policy that united public and private health sectors like never before. We tried to save as many lives as possible, and that collective effort helped reduce national mortality a lot compared to other countries in the region. But at the same time, we witnessed enormous suffering. Many patients dying in critical care, far from their loved ones, sometimes saying goodbye over the phone. And that experience changed the way I saw or we work with the intensive care team in our hospital. Together, we created symptom management protocols. We allowed controlled family visits when it wasn't allowed. For the pandemic, it was always the people was very afraid, and the public system was that everybody have to stay at home. And we offered some kind of protocols to say goodbye, to offer psychological and spiritual support for patients and families. And I think that that experience built a little bit of trust between teams and showed we can collaborate. The collaboration between intensive care and palliative care is not only possible, but absolutely essential, I think. So after that, we start to work in my hospital with the palliative care team more directly. And I think that in the country, that is not the rule. We have a good intensive care units in general, but we don't have a system, for example, a referral trigger system or standardized strategies for this practice in the country. We have a local experience, and we are trying to have data and to do projects to incorporate palliative care in intensive care, but it's not a state of the art in the country.
Yeah, yeah. So it's really through the COVID-19 pandemics accelerated some of the practice that you have then tried to continue and build on from that time. But as you say, maybe it's not systematized. It's not kind of organized in a way where there's guidelines and then, protocols or algorithms so that everybody everywhere in Chile can, access the same levels of care. That's one of the challenges from what you're saying?
Yes, and I think it's important because in Chile, between 40 and 50% of the population is dying in hospitals, and a lot of them in critical care units. This data we have a lot of mortality, hospital mortality in the country.
Right. What is driving that? Do you know? Um, is there a lot of use of private healthcare, which can sometimes drive that? Do you know why there's such a high percentage of hospital deaths?
I I'm not sure, but I think that it's the medicalization of death in our culture. Nobody talks about death. We have very few development in advanced directives, and it's very hard to put the dying issue into conversations in general. The people don't speak about death, and when you see a patient in the hospital, they never talk about that with the family. They don't have that spoken before, so it's complicated. They want to
Yes.
live as much as
Yeah.
possible.
Yes. So yeah, so that in itself is obviously going to provide that background provides a kind of big barrier in terms of then introducing palliative care itself. As you say, maybe COVID enabled some of those conversations to happen just because so many people were dying and some of those difficult decisions were happening kind of at speed and at scale. So maybe people were more open and more willing. How is palliative care introduced to patients in the ICU setting in Chile? Who decides that, and how does that happen in practice?
In practice, I think in general, we have a very paternalistic system of care. So the physician decides. That's in general. And I think also that it's a training problem there. We made a qualitative study. We published this in 222, and that we ask the ICU professionals, physicians, nurses, and nursing technicians about their point of view about a very sick and dying patient in the ICU. And we found that the ICU team genuinely value caring for patients and family at the end of life, but they face several barriers. So they are paternalistic, but at the same time, they have troubles. They feel difficulties to navigate with uncertainty. So knowing when to stop aggressive treatments. So the strong cultural pressure to do everything possible is complex for them too. And another important barrier is the lack of training. They feel unprepared, not only to talk about death, but also to navigate with families, acting as surrogates, to communicate bad news, to offer emotional support during a conversation, for example, to sustain those conversations when the outcome is bad or not clear. So I think we have a mixture of culture, but also of lack of training and of lack of trust between palliative care teams and ICU teams. I think we have to build a strong collaboration. I realize when we have a good family meeting, when we relieve suffering, the ICU team breathe. They realize that it's possible to do it better and that they don't have to do it alone. I think that's play a role also.
And are you able to include some of the intensive care staff in those family meetings? Or would it just be done by the palliative care team? Do they tend to stand to one side when you do your stuff?
It's difficult. I tried to do meetings with the palliative care physicians, but it's very complicated because what's happened is that we have some training in communication. They don't. So they don't respect the basics. So like sit down calm in a place. So hear before to speak and accept emotions. All that they don't know what to do. So when we are both physicians together with a family with complications, it's difficult to let the meeting with both chiefs in the room, I have to say.
Yes.
So I have to navigate. Sometimes what I do is that I do my meeting after the first meeting. So sometimes it's not the best choice, but we can help. And the protocol that we worked the last 3 years is a protocol that is multidimensional. So we have some communication aspect there, but we are very respectful about the hierarchy of the ICU. So we know that we cannot directly work with decision making at that point. We are focusing on creating safe spaces for families, but trying to influence decision making at the beginning, I think, is too complex today in Chile. So we have to go one step before another.
It's very common, isn't it? Because one respects the expertise of the ICU team, of the ICU, physicians who are leading the service. But as you kind of mentioned at the beginning, you are also aware of the humanity of the patients and the suffering of the families, and trying to build bridges so that those two things can come together and inform one another, I suppose, for the benefit of the patients ultimately. But also, I mean, it does benefit the system if patients can get appropriate care, when they need it, isn't it? So if you're de-escalating treatment or something like that, then that overall will benefit the system if that's the most appropriate thing to do and has been agreed by everybody. But it does take time, and it takes quite a lot of trust, I imagine. As you kind of mentioned, that developed during COVID, that there was perhaps a respect between the teams that developed that maybe hadn't been there before.
Yeah,
Yeah.
it was a start. And also the here in Chile, the universities, the medical school in general, don't have formal palliative care courses. So the ICU physicians or other physicians of the hospital never hear about palliative care before. So it's
So,
strange for them.
so as
They don't.
undergraduates, they wouldn't have any knowledge of communicating difficult issues or principles of palliative care. They would have none of that in their undergraduate training.
Yes, so they don't have a teacher, a respected teacher that works in palliative care. So you can have a good surgeon, for example. I am not a surgeon, but I know what is a surgeon, and I know that a good surgeon is respected. Palliative care physicians, senior palliative care physicians, are not so known for other colleagues. So we are rare. We are
Yes.
a little bit strange for them. So
Yeah.
it's not easy to have respect between colleagues if you don't know the other. That's why I think also it's difficult.
Mm. Yeah. So, I mean, that helps us move to the next question, which is really about how have you and your team worked to try and build some of this collaboration, when, as you say, maybe your colleagues have very little awareness of palliative care colleagues or palliative care practice. What strategies have you tried to use to build collaboration?
Yes, as I work in a university hospital, I think the academic language is respected, and research is important in my context. So it's very helpful for us that we, over the past 2 years, 3 years, we are developing a government-funded research project that aims to evaluate the effectiveness of a palliative care protocol for patients at high risk of death in ICU, in our ICU. So this protocol has been implemented in 5 hospitals across different regions of the country, including both public and private institutions. And the goal is to determine if this protocol change the suffering of our patients. So we don't yet have the final results, but we have already done the implementation of the study. And the simple underlying idea is that patients who are at high risk of dying, so an ICU patient, is also at high risk of suffering, physically, psychologically, spiritually, existential suffering. And therefore, they need an approach that should be not only reactive, also preventive. So in this protocol, we define high-risk patients as those for whom the ICU team had decided to limit or not initiate, so withdrew or withheld life support measures, and that we call adequacy of therapeutic effort. So for those patients, we propose an automatic palliative care referral and a collaborative model between both teams. So once the patient is referred to our team in the study, we perform a daily symptom assessment using standardized tools, and we teach the ICU clinical team to use these tools. This is an ESAS for communicative patients, or an RDOS for dyspnea and ventilated patients, for example. So we measure every day pain, dyspnea, anxiety, agitation. And it's quite striking, but there is very, very little experience in ICU teams in how to measure symptoms. And also, I found very little evidence published about physical symptom evaluation and management in intensive care. In a setting with so many technical tools, this area remains surprisingly underdeveloped. So I think it's positive what we are doing there.
Mm-hmm. That sounds absolutely incredible. And 5 different sensors to do that study.
It's interesting. So when we also work a little with communication, as I told you, not directly on decision making, but providing space, safe space for families, allowing them to express, to share emotion, and to channel questions, to make a bridge between families and ICU teams, for example. And we facilitate also psychological and spiritual support when families and or patients request that. So that's the protocol finally. And I think it's very successful. The chief of the ICU in our center sent us an email asking for spreading the protocol in other units, for example. So I think it's nice. Yes.
And it's working. You're getting good feedback. That's great. Yeah. Yeah.
Yes.
Do you think that you are, because I mean, I think I was listening intently about your referral criteria into the study, because I think that's, many times with palliative care, the door is closed, isn't it, for a variety of reasons, whether patients don't want to talk about death and dying, whether doctors aren't willing to talk about treatment failure, whatever it is, the door is generally closed. So it's kind of, what is it that opens the door to the referral, and when will that door open, which I think is critical, not just in ICU. This is across specialties, really. And from what you said, I think the door opens, i.e. people can be enrolled in the study at the time that no more active treatment is being started. Was that the criteria? Did I get that right?
No, not exactly. It's when any life support measure would be limited. For example, no RCP resuscitation, but still vasoactive drugs or still antibiotics.
Okay.
Or no dialysis, but still high flow oxygen. So respectful about the decision making. So, okay, the ICU team with the patient and family decide. But when the decision implies whatever kind of limitation of life support, maybe this patient could die. So please call us and we will see what happens.
Yeah, yeah. And do you feel that you are capturing most of the patients that would benefit from palliative care or through those criteria? Or do you think there's a wider population that could benefit if ICUs were more open to referrals?
I
Or-
think it's useful for my country at this moment, this protocol, but I am sure that a lot more of patients could benefit. A lot of patients dies in these units without referral. I think less than 50% or 30% of the dying people was referred to this protocol. So that's one thing.
Yeah.
And also, what I realized is that 72% of the patients in the protocol presented moderate to severe symptoms, pain, dyspnea, anxiety, and only a 30% dies. So the majority of patients in ICU are suffering physically a lot, 72%, and not the dying patient, all the patients. So I think ICU needs to address suffering beyond mortality. They just the people in ICU is suffering a lot, even if
Yes.
they survive. So I think they need supportive care, like the chemotherapy for, I don't know, head and neck cancer. They will survive, but with a high amount of suffering. I think it's the same. They need support palliative care. So the ICU needs support palliative care because patients and family are suffering a lot, even if they arrive to save their lives.
Yes. And I think the data is increasing on this. It's not something I know a lot about, but I've heard people talking about, say, PTSD post intensive care admission, the kind of recognition that admission to intensive care itself causes suffering. But then, as you're saying, perhaps because there's more of a focus on physiology than symptoms, often these symptoms may be there due to illness or whatever, but perhaps are not assessed, and certainly they're not managed if they're not assessed. So there's still quite a lot of gaps, but it's very clever and creative how you and your team have worked out this study. And as you say, it's a kind of it you talk about the safe space for the patients, but it's also a safe space for the staff and perhaps the specialists to engage with palliative care in a controlled way, isn't it? So they understand when they should refer and who needs referral. They've got clear criteria for intensive care staff members. That helps, doesn't it, to say who should have palliative care in the study. It enables people to be referred in a clear way, and it doesn't mean that an individual has to take a particular decision about a patient. They just get to a point and they say, okay, now they're going to be referred for palliative care in the study. And I think that's a good, it's a kind of building block again to build trust, and then you can present results in meetings and so on, and people can see the kind of outputs from the palliative care involvement. So I think that sounds very interesting and exciting. Do you have any idea when the results will be out?
Yes, the next month.
Oh, really?
Yes, we are working on it because the Latin American Palliative Care Congress is in March in Sao Paulo the next year. And we have to send the abstract this month in October. So we have to have the data the next week.
Great. Great,
Yes.
great. Oh, wow. And how long has the trial been running for?
Yes, it's like 2 years in total, like 3 years of work with all the things, but 2 years of recruitment. Yes,
And your
something like
patient
that.
numbers, do you know? Are you able to
Yes, yes, yes.
tell us your patient?
290. We have 290 patients recruited.
Fantastic. Wow.
Yes, we arrive, and this is less than 50% of the mortality. I believe that
Yes.
less, maybe, because I don't have the exact mortality of each unit if each month. This is local data. But when I arrived to find this data, a lot of people dies without referral to palliative care. I think it's incredible. And when you see this patient and these families, it's so useful to speak with them, to give a support, a family meeting.
Yeah.
The dyspnea treatment is so clear that we can help. It's impressive. So I am motivated because we have a lot of work to do. And also to say that it's not against the ICU, or contrary. The mortality of our ICU is, I think, between 10 and 20%. So 80% or 90% of the people in our ICUs is alive. So we have good ICUs. It's not that we have
Yes.
bad ICUs.
Yes, they're doing a good job, and they can do a better job with palliative care, isn't it? I mean,
Yes.
that's it. It's I think it's that understanding that palliative care is not saying anybody's doing a bad job. It's just saying it can add value, I suppose, rather than we're signifying death or we're closing the door or whatever. It's just adding value to care, really, because we take a different perspective on the patient and the family. And as you say, you can see how much that is appreciated by patients and families. So
I
yeah,
think it's so useful, and for the ACU team, it's impressive because sometimes I can see conflicts between nurses, physicians, senior physicians in the team, in the ICU team. And when you give this protocol with a clear tool to measure symptoms, to relieve suffering, is so well received. The nurses are so happy to say, we have dyspnea because the RDOS is 7. So please do that. And the young physician is happy to do that. And then the senior physician makes the round easier because the people is not complicated or with moral distress. They are doing something important. They are bringing humanity into a highly technological environment. And then I think that that's so good for them as teams. I hope that in the future they will have ICU palliative care teams, and then maybe we will be other palliative care teams. But that palliative care would be part of ICU because they have so much suffering there. It's part of the treatment, so they need palliative care urgently, and they will be happier too. I'm sure of that.
yes. And as you touched on the possibility to also reduce moral distress for for staff members as well, which I think is
So clear.
again is something which is being written about more. Again, post COVID, it was recognised how much moral distress came about as a result of COVID-19, and how staff members had to work in really stressful environments. But I think intensive care staff do work in those stressful environments, don't they, day by day? And helping patients, helping families can also help them, do their job to the best of the ability and to reduce suffering. So I can hear your passion in the passion in your voice for this topic, and I'm hoping that your research results will be published both in, I presume, in Spanish for the conference and for your local audience, but will they be published in English as well? Just given my own language limitations, so that we can learn from them.
We will find a good translator so we can publish it in English. Yes, the medical literature is in English, so we will
Yeah.
try to publish, yes, as soon as possible to share what we found and what we can do next. We
Yes.
know, yes, I'm sure we know a lot of things in palliative care that are very useful in different areas.
Yes.
And I think and the justice of that, the justice because the economic burden of ICU is enormous. It's so expensive. And maybe you know that we have a meta-analysis of palliative care in ICU that save days in ICU before death. That's a lot. So it's not that you rise the mortality of the unit. The mortality of the unit is the same, but the days in ICU of those who will die is less. And that's less suffering and less costs also. I think it's so wise to collaborate with intensive care in many ways.
I'm going to go slightly off track, but we're sort of drawing things to a close. But I suppose one question that I would like to ask you is thinking about, I suppose with the podcast, I am trying to reach an international audience. And, everything that you said today is relevant for an international audience. But as I was doing a little bit of research, looking at, who's doing what and where guidelines are coming out, it sort of struck me that there is, and maybe you'll tell me this isn't a gap, but it seemed to be that there is a gap in terms of there could almost be a global conference for palliative care specialist teams who are working in or focusing on intensive care, because it seems like probably globally there's quite a lot of learning which is going on. I mean, you're doing a lot of learning in Chile. I think in India there's quite a bit of learning, but in other settings maybe they're 2, 3, 4 steps behind where you are, but maybe wanting to see how they could possibly work with teams with their own intensive care services, how that could happen. I just wonder what you think, globally would be useful to try and, obviously research will be relevant and published research, but in terms of trying to accelerate research into practice in a whole range of settings, particularly low and middle income countries, I just wondered if you have any thoughts about what needs to be done for that.
Yes, it's a good question. One thing is that palliative care is high tech in humanity, and ICU is high tech in organ support. So integrating palliative care into critical care has nothing to do with abandonment. It's about high quality, bringing humanity to technological environments. I think that's universal. It's universal for artificial intelligence also. We need to bring humanity in what we do with technology, in ICU or everywhere. I think that's useful to believe. I believe that palliative care is high tech in humanity. That's useful, that's essential, that's necessary. That's one thing. And the other is we need to give a structure to the other teams to understand what are we talking about. So a tool to measure, place to make the family meeting, something concrete. So, okay, we will measure that with that, and I will be able to receive a family in that place for that time. So simple, but it's revolutionary. I think that maybe could be useful. And if somebody's interested in the protocol, I'm happy to share all what we discover, all what we write in any country. Thank you very much to give me this space, and I'm happy and congratulations to you to build this space.
Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts.